Hello and welcome to iStream Ophthalmology, learning ophthalmology made simple by Dr. K. Suresh. Today we are going to learn about diplopia charting. What is diplopia charting, how to do it, and how to interpret the outcome of a diplopia chart. Now, what is diplopia? Diplopia is a condition where a person perceives a single object as two separate objects. It can be uniocular or binocular. Now, coming to types of diplopia, it can be physiological, like anything which is beyond the Panam's fusional range is perceived as two objects. So, this is physiological diplopia, or anything because of a paralysis or any other causes is known as a pathological diplopia. And depending on whether it involves two eyes or it occurs even with a single eye, it can be monocular or binocular. And when the object in comparison to the original object where the image is being formed, we can call it as crossed diplopia or uncrossed diplopia, and depending on the orientation we can classify it as horizontal or vertical. Now, what is this diplopia charting? It is basically a test done to find out the paralyzed muscle when the patient complains of diplopia. What is the principle involved in diplopia charting? It is known as dissociation principle. That is, a single object is made to be perceived as two separate objects by using a red-green goggles. This red-green goggles breaks the binocular fusion and helps us to evaluate each eye separately. So, what are the uses of doing this? As I told earlier, it is basically used to determine the muscle that is not working. It can be done in bedridden patients also who cannot do HES charting, and where at places where HES charts are not available, we can do the diplopia charting because the requirements to do diplopia charting is very minimal. So, what are the disadvantages? It cannot be done in a color deficient individual. It needs cooperative patients who are capable of reporting the changes. Mild paresis can be missed. Cannot be accurately reproduced every time because the patient's response might differ on different occasions. So, it is not very accurate when done repeatedly. What are the requirements to do diplopia charting? First, we need a linear light source, red-green goggles, also known as Armstrong goggles, where red is placed in front of the right eye and green is placed in front of the left eye. A screen or wall to project the linear light, or the observer can show the light by standing in front of the patient, and a paper to record the patient's response. So, how is it done? A linear light is projected in all 9 directions of gaze. Patient is asked to respond as to how he or she perceives the light. The answers are recorded appropriately. So, here we see that there is a screen in front of the patient. Here the observer is shown to be standing behind the patient. Need not necessarily be done like this always. Patient can be shown the light by standing in front of the patient also. But the patient's response has to be recorded as per how the patient sees, that is the patient's view. So, the right will be in the right side and the left responses will be the left side. Why that is important is the observer's view and the patient's view are totally different. When we talk about the observer's view, it is as if the patient is sitting in front of us. So, the left eye will be in front of our right eye and the right eye will be in front of the left eye. That can cause a lot of confusion. So, it is always better to record it as per the patient's view. Why this is important? Because the muscle orientation differs. As you can see, if the right eye is in the right, all the superior rectus and inferior rectus action comes in the right side of the patient. Okay, and left side superior rectus, inferior rectus comes in the left side, which is reverse when we see in the observer's view. It is not a must that we have to record it only as per the patient's view. It can also be recorded as per observer's view, but this has to be clearly mentioned in the patient's response. So always during diplopia charting, always mark where the right side is positioned and where the left side is positioned. If the right is written in the right side, that means we are seeing a patient's view, and if the right is written as left eye, then we are actually seeing a observer's view. Before going to evaluate the output of a diplopia chart, we all have to know what are all the muscles that are responsible for the different extraocular movements. Now here, let's see what happens in dextro elevation. In dextro elevation, the right eye is abducted and the left eye is adducted. So we all know when the eye is abducted, the right eye come in line with the vertical movement, and when the eye is adducted, the obliques come into action. So here, since the right eye is abducted, the main elevator here is the superior rectus. So in dextro elevation, it is the right superior rectus that is acting, and the yoke muscle in the left is the left inferior oblique, which is the prime elevator when the left eye is adducted. Now let's see what happens in levo elevation. The same thing. In levo elevation, here the left eye is abducted and the right eye is adducted and elevated. So the reverse. The left eye, the right eye become this prime elevator, and in the right eye, the obliques become the prime elevator. So the two muscles that are acting here is left superior rectus and right inferior oblique. Now levo depression. Here again the same principle. The left eye is abducted, the right eye is adducted. So the right eye, which is the prime depressor here, acts in the left eye. So it is the left inferior rectus which is acting here, and right superior oblique. In dextro depression, the reverse of what we just discussed happens. So the right eye become the prime depressor here. So the right inferior rectus acts here, and the yoke muscle here is the left superior oblique. For dextroversion, it is very simple. When the right eye is abducted, it is the right lateral rectus, and the prime adductor in the left eye is the left medial rectus. For levoversion, the opposite. The right medial rectus causes the adduction, and the abduction is done by the left lateral rectus. Elevation, it is very simple. Both the superior rectus of right and left eyes. And likewise for depression, the inferior recti of both the right and left eye acts here. Now coming to crossed and uncrossed diplopia. See, this is a slightly confusing principle. Many people don't understand it. So let's see in detail. What is uncrossed diplopia? So normally when we present an object to both the eyes, the object is perceived at the fovea. Okay, so let's imagine a situation where one eye is slightly rotated inwards. as here the right eye is slightly rotated inwards. So what happens? The object, instead of being perceived at the fovea, it is now perceived slightly nasal to the fovea. But we all know when the point nasal to the fovea is stimulated, it projects the image temporal to the original object. That is why we call it as uncrossed diplopia, where the false image is in the right side and the deviating eye is also the right. Okay, so when the right eye is at fault and the false image is also falling in the same side, it is known as uncrossed diplopia. Here an opposite condition happens. Here the eye is rotated outwards, the right eye is rotated outwards. The temporal part of the retina is being stimulated here and it is being projected nasal to the object. Here the eye is rotated outside, but the false image is perceived nasally, and so since it is crossed, we call it as crossed diplopia, because the false image is perceived to the left of the object. Though the eye that is at fault is the right eye, the image falls in the left of the object, so we call it as crossed diplopia. So to make it simple, if the eyes look crossed, the diplopia that happens is uncrossed, and if the eyes looked uncrossed, the diplopia that happens is a crossed diplopia. So let's see how tilting of images happen with eye rotation. So here let's take the right eye as our example. So I have marked 3 lines A, B, C, D and E, F. Okay, so if a linear light falls on AB, okay, it is seen as a erect image, very simple. And if this light falls along CD, it is seen as a slightly tilted image where the superior tip is tilted temporally. Likewise, if the light falls on EF, it is seen as again a tilted image where the superior part is tilted nasally. Okay, so let's remember this. Now here the right eye, I have shown that it is slightly intorted, that is, it is turned nasally. Now what happens, instead of AB, when an erect image or an erect object is focused, instead of falling on AB, it falls on CD because of the intorsion. So we already know when the line CD is stimulated, it produces an image which is tilted slightly temporally. Okay, so whenever an eye is intorted, the image moves in the opposite direction. That is, the eye moves this side, the image moves this side. Okay, so the reverse happens when the eye is extorted. So what happens when the eye is extorted? Instead of AB, here EF comes in line and the linear object falls on EF. So as we already know, when EF is stimulated, it produces a tilted image where the tip is tilted nasally. So when the eye is extorted, the image is tilted nasally, or image is tilted in the opposite direction. Okay, so we have to remember this. Whenever the eye is intorted, the image is tilted in the opposite direction, and when the eye is extorted, the image is tilted again in the opposite direction to the movement of the tilting of the eye. The common rule of thumb that is observed in diplopia charting is, when there is a superior palsy, the tilt is towards the sound side. So let's see, let's take this eye, which is the right eye. Let's see whether, as per this rule, superior palsy leads to tilt to the sound side. Here the right eye is the abnormal eye, so as per this rule, the tilt has to be towards the left side. So let's see if it is happening. So in a right superior oblique or superior rectus palsy, what happens? Since the intorted is palsied, the eye is extorted. So when the eye is extorted, what happens? Instead of AB, any linear object it falls on EF. And we know when EF is stimulated, it produces a tilted image which is nasally tilted or towards the left. Since this is the right eye, if the image is tilted nasally, the tilt is towards the left. So superior palsy, it has caused a tilt to the sound side, or the sound side here is the left eye. Is the same thing happening in the left eye? Let's see. So here the left eye is extorted because there is a palsy of the left superior oblique and left superior rectus. Here what happens again, because of the extortion, the object starts stimulating the EF line, and EF here is producing an image which is tilted to the right. So like it says, the superior palsy causes tilt towards the sound side. Here the sound side is the right side. So we have, as per the dictum, superior tilt has caused the tilt towards the sound side. Inferiors cause tilt to the ipsilateral side. So let's see again whether this happens. Here again, the right eye, there is a palsy. Since it is a extorted palsy, the eye is intorted. Since the eye is intorted, instead of AB, CD comes into play, and a linear object starts stimulating the line CD. It produces a tilted image which is tilted towards the temporal side, and temporal side here is the right side because we are talking about the right eye. So here again, as per the dictum, right eye inferior paralysis has caused tilt towards the right side itself, that is the ipsilateral side. So let's see if it's happening in the other eye also. Here we have the left inferior oblique inferior rectus palsy. Eye is extorted, so naturally CD comes into play when a linear object is projected, and CD is visualized as a tilt towards the left side. So again, a left palsy, inferior palsy, has caused a tilt towards the left side, that is inferior tilt towards the ipsilateral side. So what have we learned? If there is a superior palsy or superior oblique or superior rectus palsy, it causes tilt towards the sound side, and if it is a inferior muscle palsy, it causes tilt of the images to the ipsilateral side. So what are the basic guidelines for us to interpret diplopia charts? 1. False image is always projected peripheral to the true image. Okay, we have to remember this. The separation of images is maximum in the direction of action of the parietic muscle. Adductor palsy causes crossed diplopia. I will explain as to why all these things are important as we try to interpret diplopia charts. So adductor palsy causes crossed diplopia. Superior muscle palsy causes tilt to the sound side. We just saw how it works. And inferior muscle palsy causes tilt to the ipsilateral side. Yes. Now let's see some examples of diplopia charts, and using the knowledge which we now learned, let's try to interpret and find out what is the palsied muscle. Okay. So as per our first thing, we wanted to find out where is the maximum separation that is happening. The maximum separation, where is it happening? It is happening in dextroversion, that is this, right? So what are the muscles that are responsible for this? It is the right lateral rectus and left medial rectus. So out of all the muscles, we have now found out that one of these two muscles are the culprits. Okay. So next, what do we try to see? We have to find out whether it is a crossed diplopia or a uncrossed diplopia. So what do we have here? Right image is in the right, green image is in the left. So it is a uncrossed diplopia. So where do we get uncrossed diplopia? Only when the abductors are paralyzed. So out of these two muscles, medial rectus is a adductor, so that rules it out. So now we have found out the culprit, which is the right lateral rectus muscle. So this is correct. So we have found out that our right lateral muscle palsy is the reason for this type of diplopia chart. Let's see another example. Here again, where is the maximum separation? Maximum separation is in levo depression here. So levo depression. So what are the muscles that are acting or responsible for levo depression? It is right superior oblique or left inferior rectus. Again, we have found out two possible culprits. Now try to see whether it is a crossed diplopia or uncrossed diplopia. It is very simple. Right image is in the right side, so it is a uncrossed diplopia. So uncrossed diplopia means, what do we know? It is the abductors which are the culprits. So what is the abductor in of these two muscle? We know that vertical muscle, the recti are adductors. So the only abductor here is the right superior oblique. So yes, so what we will get? We have found out that it is a right superior oblique muscle palsy. Now whenever we are dealing with the oblique or a vertical recti, we can use the tilt also to verify whether we have made the correct thing. So what did we learn earlier? If the tilt is towards the sound side, then it is a superior muscle palsy. That is, the superiors will cause tilt towards the sound side. Now we have come to the conclusion that right superior oblique is the palsied muscle. So let's see whether the tilt is towards the sound side, which is the left. Do we see? Yes, the right, that superior has tilted towards the left side. So yes, so our diagnosis is very much correct. So superior muscle palsy, tilt is towards the sound side, which is the left. So our diagnosis is correct. So it is a right superior oblique muscle palsy. Example 3. So let's see one more example. Here, where is the maximum separation? The maximum separation is in levoversion. Okay, so what are the muscles that act in this position? It is right medial rectus or left lateral rectus. So one of these two muscles are the culprits. So next step, is it crossed diplopia or uncrossed diplopia? It is a crossed diplopia. Why do we say it is a crossed diplopia? The red image which belongs to the right eye is in the left, and the green image which belongs to the left eye is in the right side. Okay, so it is a crossed diplopia. So if it is a crossed diplopia, then the problem is with the because of the adductors. Okay, so which is the adductor here? The medial rectus is the adductor, whereas the lateral rectus is the abductor. So that rules out left lateral rectus. So what is our final diagnosis? It is right medial rectus palsy. So it is correct. Let's see one more example. Here maximum separation is in this quadrant. So what is this? The muscle acting is right inferior oblique or left superior oblique, because in levo elevation these are the two muscles which are acting. Correct. So again, by finding out maximum separation, we have come to two muscles. Next step is crossed or uncrossed. It is an uncrossed diplopia because right image is on the right side and left image is in the left side. So uncrossed diplopia. So uncrossed diplopia means it is the abductors that is responsible. We know that vertical recti are adductors. So our muscle, all the culprit here must be the right inferior oblique. So let's see whether it is correct. Yes, it is the right inferior oblique muscle palsy. Now how do we verify it? If it is a inferior palsy, the tilt is towards the ipsilateral side. That is, here we have a right muscle palsy. So naturally we expect a tilt to be on the right side. Are we seeing a tilt to the right side? Yes, the right image is tilted towards the right side. So our diagnosis is verified. It is a right inferior oblique muscle palsy. Next example, let's see where is the maximum separation. The maximum separation is in dextro elevation. So this is the area where there is maximum separation. So what are the muscles that are responsible for dextro elevation? It is right superior rectus and left inferior oblique. Okay, so again, first observation, we have come to a conclusion that one of these two are the culprits. Okay, so next, whether it is crossed or uncrossed. So here the right image is towards the left side, or the red image is towards the left side, and the green image which belongs to the left eye is in the right side. So it is a crossed diplopia. So what are the causes of crossed diplopia? The adductors are the causes of crossed diplopia, and we know when we talk about vertical recti, they are adductors. So here the right superior rectus is most probably the culprit. Let's see whether our answer is right. Yes, it is the right superior rectus muscle palsy. Now how do we verify our answer is correct? We know that if the superiors are palsied, it tilts towards the sound side. So let's see, here the right superior rectus, the right muscle is palsied. So if it is going to tilt towards the sound side, the tilt has to be towards the left. So here we can see the tilt is towards the left. So our answer is verified. That is right superior rectus muscle palsy, which is seen as a crossed diplopia with a tilt towards the left side. So let's see one more example. What is the area of maximum separation here? It is dextrodepression. Okay, so in dextrodepression, what are the muscles that are acting? Right inferior rectus and left superior oblique. So by looking at the area of maximum separation, we have come to a conclusion that one of these two muscles are the culprits. Okay, now again let's see whether it is a crossed or uncrossed diplopia. The right image, that is the red, is in the left side and the green image is in the right side. So it is a crossed diplopia. So if it is crossed diplopia, then the adductors are the culprits. So what is the adductor here? We know that vertical recti are adductors. So that rules out left superior oblique. So our muscle of concern here is right inferior rectus. So let's see. Yes, it is right inferior rectus muscle palsy. Now how to verify? If it is a inferior muscle palsy, the tilt has to be towards the ipsilateral side. So here we have come to a diagnosis that it is a right inferior rectus muscle palsy. So the tilt has to be towards the right side. Is it happening? Yes, the tilt is towards the right side. So our diagnosis of a right inferior rectus muscle palsy is correct. Okay, so we have seen examples of all possible muscle palsies in the right. I have done all the muscles in the right side so that it will be easy for you to understand and it will not be confusing. Okay. So the take home point is always identify the location of maximum separation. You will end up with two muscles. By finding out whether the diplopia is crossed or uncrossed, we can come to a diagnosis of which muscle is paralyzed. So the paralyzed muscle can be identified with these two steps alone. And if it is a vertical muscle that is involved, we can even confirm whether our diagnosis is right by finding the image tilt. Okay, so go in an orderly way in interpreting diplopia chart and you can never be wrong. Thank you.